Hi, I'm Ryan. Ryan Seacrest. I mean, Neuhofel. Um, that's what I feel like. Because I've done so many of these moderating things, I feel like I'm becoming that. But so the reason we want you guys to share this, other than it helps, increase awareness of DPC, is because we want this session to really be about the public, the general public, who obviously isn't familiar as you guys are about DPC. So this is really going to be geared towards, just your average person who has questions about joining a DPC practice. Okay. And so that's the reason we're doing this, is obviously it's going to help kind of spread awareness of DPC, but feel free to share it with both your friends and family, which is probably a more effective avenue here. So once the stream goes live, share it. And I'm sure your friends and family probably ask you a lot of questions about this thing that you're doing or want to do. And these 4 panelists up here are, I want to call almost experts at answering these type of questions. That's why they're up here. So this will also give you guys a good example to follow when some of these questions from the general public get pitched to you. So I'm hoping that the majority of the audience on the Facebook live stream we're live. Awesome. Hey, Facebook. How you doing, Mr. Zuckerberg? I'm sure he's watching. If you guys, anyone's friends with him, can you tell him to share this on his too? Yeah, and so, we're hoping that this session with these group of 4 DPC doctors will help educate the public on what DPC is, what it means to join a DPC practice. And I'm going to get my phone out too here. We're okay though? Okay, good. And so for the public out there who's watching this, if you're interested in joining a DPC practice, or you're a physician who's interested in DPC, or someone who's interested in health policy, or any of the above, these 4 panels up here, I think will do a good job of answering those questions. So what we're going to do is start with just asking questions, and if you have something, then please let us know. So I wanted to give first a quick introduction. My name is Ryan Neuhofel. I'm a family physician who has a DPC practice in Lawrence, Kansas. But I'm going to kind of field most of these questions and give them to these guys. So starting here and then going that way.
Yeah, I'm Nick Thompson. I'm a co-owner of a practice called Antioch Med in Wichita, Kansas. We've been open about 2 years. Interesting parts about our practice are we still do inpatient care and obstetrics with our practice.
I'm Maura McLaughlin, and I am founder and family physician at Blue Ridge Family Practice, which is in Crozet, Virginia, just outside Charlottesville, and I take care of patients of all ages.
My name is Emily Scott, and I am with Halcyon Health Direct Primary Care, which I co-founded with my husband, and we are in Orange County, California. That's in Southern California.
Jeff Davenport, family doctor, DPC since spring of 2014 in Edmond, Oklahoma.
Okay, I can't type that fast, but I think I'm done. I think I shared it. Okay, so I think these questions can take many different forms, but I'm just going to start at the top here because we had a couple people pre-submit questions, and I'm going to pick 1 or 2 of you guys to answer each of these. So I am going to start with Jeff on the end there since he has the microphone.
Why do you think I kept it?
Thank you. How is this different than concierge medicine?
Well, typically in concierge medicine, oftentimes there is at least in my neck of the woods, a pretty expensive yearly contract. And that provides access to the physician, but it doesn't change a whole lot else that happens inside the physician's office. Most of them still bill insurance and collect co-pays. They aren't necessarily available for extended after-hours technology visits, weekend type stuff. So the patient benefits from the physician having a lot fewer people to take care of, so the visits during the office hours are generally extended, so one would expect that same physician with more time with each patient to do a pretty good job. But economically, to me, is where the real difference between DPC and concierge is we are actually very cost effective, whereas concierge doesn't really change a lot of at least in the outpatient setting, doesn't change a lot of the economics. As a matter of fact, it adds a whole extra layer, which typically is very expensive in my area. I won't mention any names of any companies, but if you are a very important person, you can go to a concierge doctor, and they charge $1,650 per person. And I'm a physician, and between my wife and I don't have $3,300 to waste on a primary care doctor who is still billing my insurance and collecting copays. So to me, that's the biggest difference, is the economics of it.
Okay. Okay.
And the time.
So this is a difficult question to answer. He just answered it for all the doctors in the room. We were just trying to figure out how to answer this on our brochure and our website for patients. And the FAQ we had is this concierge medicine? And the answer we put is no. And we said we charge an affordable monthly fee. And we left it at that. So that, to me, when we originally wrote our FAQ, we had prices in there, we talked about insurance, and people don't understand any of that. So I think the word affordable can go very far. I think being careful about calling concierge one price and DPC another when it can be such a moving target, it's so complex. But that's where we placed it.
I love this question because I get asked it all the time, and I think one simple way I've explained it is direct primary care is concierge for the rest of us. So it's just, I see it as concierge being marketed towards a primarily wealthy population. Direct primary care really works for everyone at every economic level, and the services provided are very similar. It's just the price point is generally different.
Yeah, and it's not double dipping. So concierge, I think, is a double dip. You're paying for your insurance, paying for the retainer fee for the concierge doctor, and they're still billing your insurance. Direct primary care is just a membership. So it's simple and easy. We say almost the same as you. This is concierge-style medicine without the valet or the white gloves.
You don't have a valet there in Wichita? I thought that was like almost, you had to have one of those.
Yeah. I mean, pretty high class.
Yeah, and some of these questions are hard, I think, for all of us. They're hard, so good job, guys. So the next question up here, and I think these questions are hard for all DPC doctors to learn how to answer them. But you guys did awesome. So can this replace insurance? I'll start with Nick here.
So what we say at our office is that direct primary care is a solution for primary care. Now, primary care is probably 85 to 90% of what everyone needs in a year, but we're not a replacement for insurance because I can't cover, from a financial perspective, your cancer, major surgery, major hospitalizations, those kind of things. What we can change the price point for and cover is primary care, which is chronic disease management, preventative care, well visits, stitches, routine labs, medications, imaging tests, counseling, a lot of those kind of things. And in that sense, we replace a lot of those things that are used by insurance but used inappropriately. So you're not going to the gas station and filling up your car with gas and swiping your insurance card. That would be silly and would make your car insurance super expensive. So instead, we use direct primary care and pay cash for those things, but you still need something for catastrophic events. And so we say that you still need insurance. Now, if patients don't have insurance or are uninsured, we still help them and care for them in the best way possible. And really, for those times when you do need to use your insurance, that's really when you need somebody on your side to be your advocate and be able to help you navigate the healthcare system. And that's where a direct primary care doctor can really shine.
I like to answer this question by saying that direct primary care can help people to use their insurance in a cost-effective manner. And especially with more and more Americans now having high deductible plans where they're paying the first, sometimes several $1,000s out of pocket, direct primary care really provides a way for those patients to control their costs and to have someone with their direct primary care physician, someone who can help them navigate the rest of the system in a cost-effective manner. And I think if patients are asking me about what insurance to choose, I mean, I tell them I'm not an insurance agent, but generally a high deductible plan, like the highest deductible that you feel like you can afford for your family, is going to give you the most cost-effective plan, because as long as you can cover that deductible if you need to, you're going to be paying a whole lot less in premiums, and you're still going to be having great access to primary care through your direct primary care practice.
I really don't have too much more to
I
add
know,
to
you
all
probably
that.
don't, because they did such a good job. Anything you got?
I've got much better answers than that. It's,
I knew he would.
no, I'm teasing. A statistic that we all throw around, 70% of the care for 70% of the years of your life are all done in primary care. But that still leaves some very, very expensive things. Cancer, surgery, hospitalization typically is kind of the three things I throw out there to patients that they understand. You need insurance. The problem is in our country, we want to use our health insurance a lot because we pay so much money for it. And I understand that thought process, but the reason we pay so much money for it is because we use it a lot. If we used every other form of insurance we have, our home insurance, our car insurance, if we use them a lot for tires and spark plugs and gas, I always love the analogy, our car insurance would be astronomical. So we buy car insurance, we buy homeowners insurance, we don't ever want to use them. I have life insurance. I don't want to use it.
But what about your wife? What about your wife? Does she?
As long as I'm more valuable alive than dead. So it's not worth much, the life
So it's
insurance.
an actuarial matter.
Right.
Really.
But that's the thing is, I tell my patients all the time, stop using your health insurance for the little stuff. It's costing you money.
So yeah, the good answers on those guys. Nick mentioned this, that sometimes you do need other people, like a specialist or something else. And so how do you guys deal with that? If your patients, you're not involved with their insurance, and like you need a specialist, or they already have a specialist, like what do you do? Are you out of the loop?
I may answer this a little bit differently so that you guys can answer that real question there. But one of the things that I do when I see a patient new for the first time and I see their list of specialists is I say, why do you go to this doctor? Why do you go to that doctor? And when they keep answering things that a primary care doctor should be handling, I say, well, do you want to continue to go to that doctor? So just a concrete example. Why do you go to your heart doctor? Well, I have high blood pressure. Okay, well, what do you take for it? Well, I take lisinopril. Okay, so do you really still need to see the heart doctor because I can give you your lisinopril? So I'll answer that question that way, and then they can talk about referrals. But we actually eliminate a lot of referrals that patients have had in the past and ongoing specialist treatments when they're not even really needed. And I would think, I mean, I don't know if there's any specialists in the room, but I know there's specialists out there who just get sick and tired of treating stuff that's so benign that they really think primary care doctors should take care of. But anyway, I'll stop there.
So with the extra time that we have as a DPC physician, we can really do so much more than we did before. So I find myself referring a lot less. I've been using a service called Rubicon, which is an e-consult service that I've found really invaluable. I think last year they were here at the DPC Summit and they stood up and they used me as an example of somebody who put in lots and lots of consults because you don't have to pay per consult. But really, I can be a dermatologist and an endocrinologist and a rheumatologist to a degree just by using this consult service. So I've found that my line is when they need a procedure, they need surgery or a scope. When I have a patient I've diagnosed with lupus and they need to be on treatment now, then I'm going to get them to the rheumatologist. So I'm taking things so much further than I did before, and it's really fun to do that and be a real doctor.
I agree with both of those, and additionally, I think I have so much more time now to actually talk with specialists. So I have patients in my practice who have been followed by specialists for years, and sometimes it's the patient initiating, saying like, I don't like traveling all the way across town, or this is really getting expensive for me. And so I have called those specialists and talked with them, and they are thrilled to have a primary care doctor contacting them, and many times they just give me the information that I need, and I will take over following that condition, and then, you know, I can always get them back if needed. But there really is the increased time with direct primary care really allows, I think, all of us to care for a bigger breadth and depth than we were able to in the fee-for-service model.
And I'll answer this. When I have patients ask me this question, what do I do about the specialists? I say, if it's something I can manage, I'll take over. If it's something that we can consult through our online clinical consult service and I can get enough information, we'll take over and get the assistance from the online clinical consult. If it's something where you need to go see a specialist, you might need to go see a specialist. And then I'll actually talk with them and communicate and make sure that that's something that is actually going to happen and happen well, that they have questions that they're going to be answering, and that we get the information that we need. So a good example of this, I have a patient that was needing to see the MFM for a pregnancy-related complication. Contacted the MFM, made sure it was an appropriate referral. I actually went with the patient to her appointment, got all of my questions asked, and made sure that she was advocated well for. And then she doesn't need to go back and see the MFM because I'm going to take over all the care from there. So it streamlines a lot of that from the patient perspective, saves her a ton of money. So,
Okay, this is one from Facebook in the same vein of these questions. What if they have an HMO? What if the patient has an HMO and you need to make a referral? This is kind of gets into technical weeds, but how do you guys manage that?
So I can answer for Virginia. I think this is one of those things that can be very location, state specific. The insurance market went just haywire in the Charlottesville area this year, and there was only one product offered on the ACA exchange, and it was outrageously expensive, and it was actually an HMO product, but it's a strange type of HMO where it doesn't affect the referrals. So I do have patients who have that, but I'm able to still make referrals and do everything I normally would, and it's no different. I don't know if either of you have.
So we've been around and around with this. We've tried having partnerships with physicians who are in the HMO, primary care physicians, and some of them are more open to it than others. You know, we give you a call and we tell you what's going on, we send you documentation, and you put in the referral. But some patients, some physicians in the HMO system have really been angsty about this and angry. You know, why am I the one that is doing all this work and you're getting paid, but they're getting paid too. But so it's very sticky, and we will tell patients when they come in, when they have an HMO and they want to sign up for our practice, we don't say, no, you can't join our practice. But we really try to explain to them that if they need anything outside of an x-ray or a lab test, that they're going to have to go back to their primary care doctor. We work with where Kaiser is in Orange County, and Kaiser is this very closed system. We can't even order a lab or give them a medication that will be covered. So when people, and we still have patients in our practice who have Kaiser, like a handful of them, which is crazy to me. They pay for Kaiser and then they come in and pay cash for everything. But they find value in what we do and they understand what they're signing up for, so we don't say no.
Depending on their deductible or copay, I always just talk them into paying cash for everything. $55 x-ray, $450 MRI. So do you want to go jump through all these hoops, see your HMO doctor here in like a week when you can get in, and then they'll spend another week trying to get the paperwork through, and they'll have to justify it, and it'll get denied, and they'll have to do a prior authorization. And 3 weeks from now, you can have your MRI, and it'll cost you 20%, and they'll charge you $3,500. So someone do that math. What is that? $700? Or you can pay $450 cash, and let's do it tomorrow. So I talk them into paying cash.
Or you can come to Wichita and we get our MRI for $235.
Yeah. Yeah. One of the things you'll realize is DPC doctors are pretty competitive, including
That
with
price
each other.
just got cut by almost half with
Yeah.
negotiation over the year. So
So if anyone's watching who doesn't believe healthcare prices and costs can be lowered, just talk to some DPC doctors in their community and what's happened over the last 5 years. It's quite.
This is the rising cost of healthcare.
Yeah.
This is the rising cost.
Yeah. Nick, you mentioned something about specialists earlier, something about online. Can you tell more about that? Like, what does that do for you, and how much do you utilize that type of thing?
sure. Yeah, so I think Emily mentioned some too about a service that we use called Rubicon, Rubicon MD. So this is something that most DPC docs, or I would say many DPC doctors use. It's an online clinical consult service. They have about 100 different specialties. The physicians actually pay for this, but then use this most of the time as an added value to their patients. So I had a patient the other day. She came in 2 months postpartum. She was having some weird symptoms, some joint pains. She hadn't lost a bunch of her pregnancy weight. We did some labs. She had some weird thyroid numbers. Sent that off to an endocrinologist and a rheumatologist. She also had a positive ANA, which that's like everyone's worst nightmare. What do I do with that? I'm the family doc. Well, I went and looked it up on UpToDate, and I came up with my own conclusions. But then I had an endocrinologist and a rheumatologist say both, this doesn't really look like this is, primary rheumatology. This looks more thyroid. And the endocrinologist said, this really looks like postpartum thyroiditis, and I would manage it in this way, and the patient doesn't have to go see any specialist. And we're monitoring her TSH for $1.70 every time we check it. So that's kind of an example of how we use that online clinical consult service.
That seems better and cheaper than what usually happens.
Yeah. And the patient said thank you. So that was, it's exhilarating. It makes doing actual medicine fun because I get to give great service to a patient that I really care about, and they really appreciate it. And it makes it worth the $45 a month that she pays at my office. So
awesome. This might be a big segue, and this one got upvoted here. What about your medications? We've heard some of you guys at least can do cheap meds. How do you manage when people, have a chronic disease and they need medications? How do you handle that?
Yeah, so at our office in Wichita, in the state of Kansas, it's legal for physicians to prescribe medicines directly to our patients. We're not a pharmacy, so we don't dispense medicines to the general public, but I can dispense medicines to patients that I'm their primary care physician for. So I purchase medicines from several different companies, the same places that Walmart and Walgreens buy their medicines for, except since I'm a direct primary care doctor, I don't profit from those medicines. I dispense them to my patients at wholesale costs. So, for example, we mentioned lisinopril here earlier. I can buy 1,000 lisinopril for about $6 or $7. I dispense them at my cost, which is 66 cents for a 30-day supply. And that's the same way for about 180 different medicines that we stock at our clinic. This is a huge benefit. So if you send your patient to a pharmacy, they can get it for $4 or a $15 copay or 66 cents at your office. It doesn't take very many medicines to end up covering an entire month's worth of membership.
What about doctors who can't do medications out of your office? I know
I was just going to pass the
you're
microphone.
Jealous now of Nick, but what about if you're in a state where you can't do that?
I'm in Virginia, where it's not impossible, but it is challenging, and so I have not added that, although I may at some point in the future. So it depends on the patient. So I do, even though I'm not billing insurance, I do pay attention to the form of insurance that a patient has, because it matters for them for any care that they're accessing outside of me. So if a patient is uninsured or they have some sort of plan where they're going to be really paying out of pocket for their medication, or if you don't know this, sometimes it's cheaper to get the cash price at the pharmacy than to actually use your insurance, which is insane, right? Like, you might go and the copay for the medicine with your insurance is $20, and the pharmacist in some cases have gag clauses where they can't even tell you it would be cheaper, but if you ask, it's actually cheaper. It might be $4 on their cash price. So I will go through with the patient if they're going to be paying for the medicine themselves. I use GoodRx a lot, which will allow me to print off a coupon right there with the patient. We also have a local independent pharmacy right in my community. The pharmacist there is amazing, and he will work with patients. He, unlike a chain pharmacy, he can decide how much he wants to make. And so I've had multiple patients come back to me and tell me that he gave me the best deal. I priced it around and he gave me the best deal. So having kind of those relationships within your community can be really helpful as well.
So basically what they both said, we have our pharmacy in our in our DPC practice. And one of the things they didn't mention was the value add when people come in for an acute condition, especially, you know, the mom bringing their kid in for otitis, and here's the amox, and it's, you know, $1. So they really benefit from that convenience too.
I'll ask you a much tougher question.
You may proceed.
Thank you, Jeff. Thank you, Dr. Jeff. What about emergencies? What if someone has an emergency and you know, what do you do with that?
Well, first thing, what's your definition of emergency?
Thank you.
I don't know if there's any ER doctors in the room. I don't know what the statistics are for the number of things that show up in an emergency room that are really primary care. The way we know and understand our patients, the relationships we have with our patients, you know, sometimes chest pain really is just gastritis, and sometimes it's something more severe. But even little stuff like bumps, bruises, sprained ankles, even fractures, lacerations, all kinds of things can be handled in a primary care office. You know, if it's a heart attack, I want them to go to the ER. But if it's just my ear hurts and it's Saturday, then that's what I'm for. If it's just I was fixing steaks on Sunday and they just need a few stitches, then that's what we're for. So what about emergencies? True emergencies, they're still going to go to the emergency room. That's where things like insurance show up, the big stuff. But we actually save patients so many ER visits, so many urgent care visits, because we're basically available, I say virtually 24/7. I rarely get called in the middle of the night, only when a kid swallows a tack or something like that. That's a true story. But in general, especially for urgent stuff that really is just urgent, not emergent, we can do as good, if not better, frankly, than a lot of the urgent cares.
So we have in our contract that we are available for urgent visits or after-hours visits for a fee, but I've never charged a fee when I do it. So there's an expectation for people that we're available 9 to 5 in the office and then by the phone outside the office. And I've made decisions. Sometimes my sweet patient, who I've been in my practice for 2 years, come to see me one time. They're getting on a plane and they've got a pilonidal cyst, right? And it's Saturday. And I'm like, meet me at the office, right? Let's just take care of this. I'm so sorry this happened to you. So there are situations where I want to rise above for them and take my time out and do it. But, you know, calls I've gotten this time when I'm here and someone has to go to urgent care because I'm over here and it's Saturday, right? So, and people understand that and they're not upset.
So I love procedures and kind of the stitches and skin glue and all of that. And one of the great things about DPC is we can do that. And so I had a patient who, it was like 5:30 Friday afternoon. I was home with my kids. Patient called me. He had been chopping wood for a fire pit with his kids. An errant piece of wood flew up and hit him in the face. And he texted me and said, I have a lac through my eyelid. And I was like, really? Like, so I call him, and then he sent me a picture, and it was near his eye, but not associated with the eye. So anyway, I said, give me 15 minutes. My husband's coming home. He can stay home with the kids. I met him at the office. He's there with his kids, who are also my patients. We fix it up. I charge him $30 for the supplies. You know, there wouldn't have been any urgent care in our area that would have been available to do that. He would have been sitting in an ER for hours with his 2 kids. It would have been a bill of probably at least $1,000 by the time he got through with all that. So, you know, that more than covered his family's care for the year. You know, the price they were paying to be my patient for the year was covered with that one visit. So something like that, it's fun for me, it's totally doable, and the patients really appreciate it.
Well, I'm going to tee this one up for Dr. Nick here. I've heard of several of these other doctors like to do procedures. So you could probably list about 700 procedures you do, but explain, you know, maybe what the scope and depth of some of those things that you guys can do in your office.
Yeah, I think this really just depends on the physician and what they're comfortable with. At our office, we also love doing procedures, and this is really a huge way to add value to your your practice. So I removed a 10-centimeter lipoma yesterday afternoon before I got on the plane. It was awesome. It was wonderful. We do lots of skin-related procedures, joint injections, casting, lots of cutting out stuff. So that's fun. This is fun stuff. The reason why primary care doctors don't usually do this stuff is because you have 10 minutes to get it done. And you can't do that in the fee-for-service world. And your time to an administrator is more valuable seeing 50 people in a day than taking time to research a procedure and figure out how to get it done. So some things that most primary care doctors wouldn't do necessarily, but that we do at our office or have done at our office. So I have a patient with a condition called Dupuytren's contracture, and he couldn't get his finger straight because of a contracture there. And so I did some research, consulted Rubicon, did a lot of reading in journals of different means of correcting this. Ended up doing a needle aponeurotomy, which is a procedure where you go in and use a 25 gauge needle and open, reduce the aponeurosis, and he's got perfectly straight fingers. And that was $15. He could have went to the hand surgeon and had this done for a couple $1,000, or had an injection of a collagenase medication, and that is about $1,200 to $1,500 a vial, and usually takes 4 to 5 vials and recurs in 3 to 5 years. Or he'd come to my office for an hour and $15 and his membership, and ended up with the same result. So these are the ways that you can give your patients great care, and you can expand your scope of practice that's fun, that really challenges you and gives your patients huge value. So thanks for the tee up.
No problem. I know you'd nail it. So I mentioned, several of you guys mentioned this, but what do you guys think about like telemedicine? I mean, that's kind of a big deal now, where people have like an app and they can go on and talk to a doctor. And you guys mentioned something about like a picture. And so how do you think that changes the way you can care for people?
So for us, we use a communication platform that allows our patients to see all of our messaging through the staff and me and my notes. And so it's very open to them, and they can message me anytime on there, and we commit to respond within 1 business day. So I'm not constantly bombarded by texts, and my patients feel that they can offlay their questions the minute they have them. So that's been really effective for us. I compare what we do to the go online and find a random telemedicine doc. It makes a huge difference when you have that relationship with someone and you know them well, versus just jumping on and getting the doctor, whatever doctor is working for that telemedicine company that day. So I think we add a lot more value having that relationship and knowing our patients.
Just to reiterate that I can appreciate the question, and people in the audience or people online may understand the term telemedicine, but I get a little bit fired up. I try to say, look, I am not practicing telemedicine. I'm a direct primary care physician, and I'm using technology to my advantage. A telemedicine doctor or provider many times is some random person who does not know the patient somewhere across the country. They can't lay hands on them if they need to. And a lot of times, if they can't manage it, they just send them to the ER, the urgent care. So it doesn't really provide a lot of value. Versus what we do, we already know the patient. We know which ones are kind of holding back. We know which ones are a little bit over-exaggerate things. But using texting and emailing and those types of things, we can provide a lot of benefit, significantly more benefit than telemedicine providers. And lastly, I always tell my patients, since I'm not incentivized to see you in the office, I'm paid to take care of you. I'm not paid to see you. So if we can use technology to take care of you, and that works for you and it works for me, and we provide good care and everything's hunky-dory, that's what you're paying me for.
back to maybe the procedure thing. Nick, you mentioned something about pregnancy. I know that's not done in all DPC practices. And for the audience out there, several of the doctors have mentioned stuff up here about, their prices and the procedures they do. And we should clarify that every practice is unique and that they do their own things. But Nick, I know something you do unique is pregnancy. And does that include the membership? And how does that work?
Yeah. So there's a variety of practice styles, but family doctors are trained to do obstetrics and prenatal care. So there's quite a few direct primary care practices that provide prenatal care, and there are a few practices that still deliver babies. This is like the funnest part of my job. I love that. And it's very challenging and something that adds a ton of value to our patients. And it's a great way to grow a young and healthy practice in general. So at our office, we have a membership for routine care, and then we have a pregnancy membership. So it's $75 a month while you're pregnant, and that gets my time, the additional malpractice that I need to be able to see pregnant patients, as well as our physician fees for the hospital delivery. And then if the patient is insured, we help them to try to manage those costs as far as the out-of-pocket expenses, hospital delivery charges, or if they're uninsured, we end up being really the least expensive route, and then we help them with financial assistance through the hospital that we deliver at. And really, this is something where the service that we offer is really accessibility, somebody that really knows you and knows your family, and also somebody that's going to follow up with you following the delivery. So you get the same doctor that knows you through your pregnancy, delivers your baby, and knows your family and helps grow with that family over time. And that's a ton of fun. So, does that answer your question?
I believe so. Okay. So when you guys, get a new patient in your practice, how does that work? I know most people call and schedule a visit. So for a patient who is, wanting to join a DPC practice in your area, how do you guys onboard them or get started?
Yeah, so when I'm scheduling my patients, so usually I will talk with them or meet with them in person before they join the practice just to make sure it's a good fit. But when they actually come in for that first medical established care visit, I always tell them, plan for 60 minutes for the visit. And people say, I've had multiple people say, I could never spend that long with a doctor. And I say, believe me, once you get in, when we have the time, once they start talking and we're kind of going through any active concerns, I try to go through, thorough past medical history. It's amazing. We spend the hour and people feel so heard and so valued. And I think the bond that comes from that first long visit, it just kind of carries you through, and you really kind of know who the person is at the end of that visit, and that helps so much. Like other people have been saying, like when we're talking, someone calls on the phone, I know immediately who I'm talking to, I know who they are, and that really helps me to be able to make decisions about what's best for that person. And I've had multiple people at the end of the visit say, this is the longest I've ever spent with a doctor in my life. And I think that's really the essence of our model, right? We have time. And so for me, that long first visit is really a way to kind of seal that with the patient, and they really believe, this is something different, this is something worth paying for.
So what she said, plus when our patients come in, they walk in the door, and the first person they see is me. All of our staff stand up. We all go over, welcome to our practice, nice to meet you. I take them back. We do this hour-long talk. And then at the end, one thing that someone was mentioning, but I think it was Delicia, was saying, her patients don't really read the contract. We make all of our patients sit with our medical assistant, and she goes through the whole thing with them. And she makes sure that every patient knows all of our communication expectations, all of the rules, what it means. And even then, we've had some people who 6 months later call and they say, but I have insurance. We're like, you've been paying us for 6 months and you still don't understand the model. But it is really important to go and have that conversation with people when they come in. And one other tip for us is, as we got busier, we have the Hint integration on our website, so you can just click join here. And people will sign up and give you their bank account, and you just push a button and you can start billing them. But once you start billing them, then I think Phil can tell me if I'm wrong, but you're responsible for their care. So we have a bit of a wait now to get in for our new patients. So we really have to be careful not to start that billing until a patient has come in and had an appointment and seen us and started to establish care.
Usually 60-minute visits, and a huge portion of the first part of the visit is just reviewing what they have to sign up online to get into our practice, and so they already put all their history in. But I review it. Typically, it doesn't take very long, but I spend a lot of time looking at their medicines and saying, we sell this here for $4.50 for a 100-day supply. We sell this here for $3.20 for a 100-day supply, et cetera, especially if they're kind of that middle-age group where they're maybe on 4, 5, 6, 7 medicines. And so I spend so much time looking at their specialists and saying, do you need to continue seeing this doctor? And then looking at their medicines and saying, how much does this cost at the pharmacy? Why are you on this medicine that costs you $50 a month versus this other medicine that is the exact same thing? Oh, look, this is a combination of 2 generic drugs. We could sell you a 100-day supply of both of these drugs separately for $9, and you're paying $65 a month for the combination. So I spend so much time in just that first 20 or 30 minutes trying to find ways to save them money, and identifying and educating them that this is why the membership, this is why DPC makes sense for people. And then I'm shameless. I say, now go tell all your friends.
Well, we've been asking all softball questions, and we have 17 minutes left, so now we're going to get into hard questions. And it sounds like you're pretty passionate, Dr. Jeff, about saving people money, but some people don't have any money. So what do we do about those patients and people in your community who don't have any money, who might be on Medicaid or need public assistance? How do you reconcile that with your practice?
Well, in my practice, I'm in Oklahoma, and I'm actually very frustrated with respect to the Medicaid question. I used to have Medicaid patients. They would actually pay out of their own pocket. Sometimes they even had a family member who would pay for them. But my state, in all their wisdom, has made Sooner Care, which is a stupid name. Sooners are bad anyway. I'm an Oklahoma State guy, so I apologize. But Sooner Care, they won't honor anything that I order. They won't pay for medicines. They won't honor referrals. They won't honor tests. So all the Medicaid patients that I was seeing, I no longer see, which is really disappointing to me. But along the lines of taking care of people who need help, at least in my practice, I take care of about 10% of my patients. Those who know me, and I've said this many times before, I love Jesus, so it's kind of my tithe to the community. So I take care of about 10% of my patients for absolute free. I call them scholarships. And sometimes there's even, one of my patients who will say, I know this person, I need you to take care of them, I will pay for them. And I say, no, I got a scholarship program. We'll put them on the scholarship program. And if you want to pay for someone else, maybe we could do that. But I think when you have the time and a business model that provides you with a good reimbursement for taking care of a fewer number of patients rather than seeing 30 people a day, it darn sure opens you up for more altruistic activities. A cardiologist in my town, Dr. Horst, who has passed away just a couple of years ago, I was talking to him about, participating at a free clinic called Ministries of Jesus, and he would spend a half a day a week there, and I would say, I'm so honored by you, volunteering your time. And he said, Jeff, back in the old days, I could volunteer 2-3 days a month, But as reimbursements have gone down and having to see more patients, it just ate into his time and ate into his income and ate into the ability to see people and accomplish what he wanted to accomplish. And so he lost time as a cardiologist where he wasn't able to be as altruistic as he chose to. But in direct primary care, we can. So that's my personal story. I'll pass the mic.
similarly, we have a number of patients who are at a discount or that we don't charge for care. These are people that I've worked in the community for 10 years before we started doing this, and worked in an FQHC, and people had followed me from that. So some people that really needed the care that I knew very well, and felt comfortable that this was a true need. So, and those patients are still with us at a discounted fee. And we have had a couple situations, well, actually just one situation where a patient wanted to pay for another patient's membership, and she did for several years, and then now we covered her free for 6 months, and then we're going to charge her half price ongoing for the future. So.
One of the things that I think is wonderful about DPC is you can hear all the different ways that we're making it work to take care of the patients in our community. And so I do sort of similar things. I have some patients on Medicaid who are being paid for by family members. I have others who I don't charge anything. And I find what's fascinating about that is I was seeing a patient recently, I'm seeing her for free, but she got out her wallet at the end of the visit, and she's like, I want to pay you something. And so sometimes people really, they appreciate what we're doing and they want to pay. So she paid me $15. And that, it made me feel, valued that I know she doesn't have much money, but she wanted to do something to show her appreciation. And so I think most DPC practices, we might not advertise it because it's not the best business model to say free care for all. But I think most DPC practices do provide some level of free care, whether it be a limited time for a patient who is down on their luck and has a few months where they're not going to be able to pay, or someone that we've known a long time that we want to continue caring for. And so there's so many different ways to do it, and it's really a beautiful thing to be the one to be able to decide that. I was an employed physician in a large academic center before, and we weren't even allowed to downcode visits. So, I was seeing a patient, and I knew their whole social situation, but, I couldn't do anything about it. My hands were tied, and so it's really wonderful for me to feel like I can really meet the needs of the people in my community.
Yeah, and I think, so we have similarly some patients that we decrease the price of their membership or give free care to, but we also set our membership prices considerably lower than the average direct primary care. So our average price, I think, is like $37 or $38 a month. And we did that because we knew our business model could handle that. And we're in an underserved part of Wichita. And it's really awesome to be able to not have to discriminate down or up. When people come into our office, it doesn't matter who you are. You're going to sit on the same couch. You're going to get the same care. You're going to receive the same amount of my time. And I'm not going to treat you differently based on whether you're the CEO of this company or somebody that has Medicaid or somebody that's kind of working poor. You get the same me and the same care regardless of who you are. And that's a wonderful part of direct primary care. You walk into a fee-for-service office and you're uninsured, you get different care. You have to. It's the way that the world works. So not having to discriminate up or down and giving excellent care to everyone is beautiful. So,
and you mentioned something about your patient population maybe is a little different because of your pricing and mission here, but can you kind of describe your your average patient here?
Yeah, so our patient population really varies a ton. So my patient panel is about between 45 and 50% uninsured. So this is a population that is kind of in the donut hole between making too much for Medicaid and not being able to afford insurance. I have a portion of patients that are from employer groups. I have a portion of patients that are privately insured or have a cost-sharing ministry. And this is probably very similar to a lot of direct primary care practices where we have patients from a whole variety of backgrounds. But the nice part is you can set it up in a way that will care for everyone. So
I have a similar mix. And I think one of the amazing things about DPC is it works for different people for different reasons, but it works for just about everybody. So I have patients who have no insurance or a high deductible plan or a health share ministry, and they really sought me out because of the financial model, because they will save money by seeing me. And then I have other patients who have Medicare or a more traditional insurance plan that covers most of their care that they would obtain, and they sought me out because they want a doctor that knows them, and they want to walk into the practice and be seen and be heard and listened to. And so it's really neat to see the different pieces of what we do with everyone appeal to different people for different reasons.
I'd say one difference about our practice is we have very few uninsured patients in our practice, I think by virtue of the location of our practice. And what my experience has been with the number of uninsured patients we have is that they get insurance and they say, okay, now I'm insured, so I'm going to go to my insurance doctor, and then they come back.
Excuse me, I actually don't even track any of this. My guesstimate is about 50% insured, 50% uninsured. I have about 40% of patients between 20 and 49, 40% from 50 to 64. I have very few Medicare patients. That's their decision, not mine. I love taking care of that age group. Probably about 5%, and then 15% kids. About 55% women or female, all ages. So that's kind of my demographics.
Well, one thing of note, again, for the audience, any prices that are mentioned are their prices, not representative of all DPC. And a little editorial on my part. For all the people who think that DPC doctors are taking care of the healthy and wealthy, please watch this panel and listen to these 4 people, because these are very representative of the DPC doctors I know. So you guys are doing obviously awesome work. And I know it gets under our skin a little bit when we get that kind of characterization. And you guys are obviously destroying that, that notion, false notion.
Yeah, we're pretty awesome. I wasn't
going to go that far, especially being from Oklahoma. But we're not all perfect, Jeff. Some of us from Oklahoma, some are from Kansas, and anyway, okay. So again, we'll go with some tough questions. What about pushback from physicians in your community, whether they be employed physicians or physicians who don't understand what you do? Do you guys get a lot of flack or criticism? I know it's a tough question to answer, and you don't have to mention anyone specific, but how do you guys handle that, or does it even happen?
The funny thing, well, first of all, most of the physicians I talked to before I actually transitioned did not think it was wise. My stepdad is a family doctor, and he told me it would fail miserably. And he's at the retirement age, and so he talks to me all the time about, will you hire me for a couple more years at this point, jokingly, because he'd never make it in DPC. He likes to be in and out. He doesn't like to spend time. But the interesting thing I thought in my neighborhood is I was literally a half a mile away from a physician who went to this conference when it was in San Antonio a couple of years ago, or whenever it was. And she converted to DPC and joined another DPC company. And I was confused by that at first, and I saw her at a meeting, and she was like, well, I didn't even know what DPC was. And I'm like, I am literally a half a mile from you, and I've been doing it for 2.5 years. And so my point is that I've come to the conclusion that a lot of the employed physicians are so isolated from physicians who are not employed by their hospital. They only see the other employed specialists. They only see the other employed family doctors. And so they're so isolated that they don't really even know what's going on outside of their system. I found that kind of fascinating. So that's something that we all have to correct. We've got to tell our colleagues about this.
I think one thing, and I have a heart for physicians who are struggling in traditional system. I had a HMO patient recently who had come to me. She got her mammogram through her HMO doctor, but the doctor didn't have time to do a clinical breast exam. And I did an exam, and she had a mass, and so we needed to do an ultrasound. And so I ordered that, and then she ended up needing a biopsy, and the primary care physician was just furious. She said, this is my patient. She has to decide if she's going to see you or me. I'm not doing this anymore. I don't feel okay with this, and she threw a big fit. And that was the first time I've really come up against someone so angry about it. And I think what I can do, the position I can come from, is understanding that it's difficult in that position, and seeing someone on the other side, there might be a little bit of jealousy or frustration about us being able to do this. So I think that's something to look out for, and have empathy and understanding for your colleagues who are still grinding away while you're floating by on your DPC happy place. So
I think this is a real thing, and I trained at the same institution that I worked at for 9 years, so I was part of this sort of tight-knit academic community while I was there, and then I left to do DPC, and it was, for a while, very frustrating for me because even in explaining to people what I was doing, I did get a lot of pushback and a lot of questioning and sort of almost like accusing, like, who are you to leave the system? Who are you to leave and leave all of us here? And what I came to realize was, yes, to just sort of have empathy. I think when you think about someone who's maybe done their whole career in the fee-for-service system or in academics, they've sort of devoted their life, and we, those of us who worked in that system know how much you sacrifice just to take decent care of your patients, how much of your personal time and your family time that you sacrifice. So I think there's a lot of defense mechanisms that come up when people hear this new idea, and it sort of challenges what they may have spent years or even decades of their life doing and supporting. But the fascinating thing is now I've been in practice 2.5 years, so I have physicians who are now interested in being my patient, and I have physicians kind of pulling me aside and saying, hey, what is this that you're doing? Like, how did you get started with this? And I'm really interested in this. And so I think it just takes time. And so I've learned, I'm naturally impatient, but I have learned to try to be more patient with that and more empathetic and patient with those who this is new to.
And the only thing I would add to that is, I teach also part-time at a local residency, so I'm somewhat involved in academics, and the academic community sometimes has a little bit stronger pushback for DPC, but that's not the case among residents. So 50% of the new residents at in the incoming class for interns at our residency expressed an interest in doing direct primary care in the future. So they really get this, and this is something that I think as we continue to train those upcoming classes of residents and doctors coming out, this is something that they see, and they see it as a way that they can practice the style of medicine that they're really looking for mentors for as well. So if you're doing this, pick up a resident, pick up a student, get them in your clinic with you, show them the way that this can be life-giving and exciting to practice medicine.
Okay, we just got a short time here, so really going to put a tough question to you. If you had about 20 seconds to convince a patient that the DPC model was for them, what would you say?
Do you want a doctor that has time for you and really cares for you, can see you the same day, makes medicines, labs, imaging tests all inexpensive, and is there for you when you really need it? If so, then you should have a direct primary care doctor. If not, you should go to the same fee-for-service doctor that you've always seen.
I don't think I can improve on that, so I'll just give I'll give one other tidbit. Something that I've learned is people can sense desperation. So in the beginning, I was just desperate. I had no idea if this was going to work, and I think that comes across. Now, my panel is full. I have a wait list, and people can just sense it. And so when people start sort of, if I'm explaining the model and they're giving me all these reasons that it doesn't work, instead of like arguing back, I just say, well, it's not necessarily for everyone. And then what happens is they're like, well, but I think it could be good for me. I mean, I really like that you do this and that. So it's almost like reverse psychology, and it's just fascinating. I mean, try it. It really works.
That's one thing too. I keep finding physicians who are getting started, and they're like, how do I sell people? How do I sell people? And it's a challenging position because you're a physician, and you have to be I think we have to be in this place where we don't look desperate for this patient to come see us. So it is that balance, and I think you strike that well.
I can't really beat anything that Nick said. It was excellent. To me, it's just we are not used to selling ourselves. You know, Julie is always so inspiring when she talks, and she's going to kill it tomorrow to close it down. No pressure. But every time she talks, she says, "We are so awesome." So take 20 seconds and tell them how awesome you are. It's not that complicated. We can offer a lot to these people, and they need it. And that's the other thing. They don't even know that they need it. They just think the way things are is the way that things that should be. So do not fear telling them how great direct primary care is, because it is. There's no such thing as perfection, but this is so much better than the system that they're in. So tell them that, and don't feel bad about it. Don't feel bad about talking good about yourself.
Well, I think we are out of time, and those were all awesome, and thank you guys. The Facebook audience, if you guys have more questions, DPC doctors are a ravenous bunch, and will answer almost any question you have, probably all night long. So if you have more questions, feel free to post them on there, and I'm sure you'll have a slew of us on there answering the questions. So thank you guys so much for tuning in.